Having the right clinical staff with the right skills at the right time is a daily, if not hourly, balancing act in providing high-quality patient care. Today we have representatives from Midland Memorial Hospital in Texas who will explain how their use of predictive analytics improves their nurse staffing levels, enhances the patient experience, and reduces healthcare costs. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hetterly, senior writer in AHA's Washington office, and your podcast host. In this podcast, part of the Members in Action podcast series, Joan Risner explores Midland Memorial Hospital's use of predictive analytics.
Hello, I'm Joan Risner, Director of Member Relations at the American Hospital Association. This podcast series is part of the Value Initiative, which highlights steps hospitals are taking to improve affordability and value for their patients and communities. These members have implemented strategies that enhance the patient experience, improve quality, or lower cost. In this Members in Action podcast, we will focus on Midland Memorial Hospital's use of predictive analytics to manage its nursing workforce. Joining me to talk about this is Bob Dent, Midland Memorial Senior Vice President, Chief Operating Officer, and Chief Nursing Officer, and Dr. Brandy McDonald, Director of the hospital's Clinical Operations Division. So let's go ahead and jump right in. And Bob, I'm going to have you start out by giving a little bit of background about your use of predictive analytics and why you started the initiative.
Here at Midland, we embarked on the work with our patient classification system and the predictive analytics probably about 10 years ago. And really it was a matter of looking at the evidence-based nurse staffing guidelines that have been published in literature for quite some time, and then be able to map that to our electronic medical record to really get to the acuity of the patient, and then look at the history of admissions, discharges, transfers, and anything associated with the nurse time. So then we could map the acuity of that. And so while we look at the number of nursing hours budgeted, if you will, at the 50th percentile or whatever arbitrary number that you budget for the department, we can input that. And then based on the acuity of the patient, we would then be able to assign our nursing staff to a patient load, not necessarily based on a ratio basis, because we're not proponents of ratio staffing, recognizing that not every nurse is the same and not every patient is the same. And so with the patient classification system and with the predictive analytics of understanding volume over the last 2 to 4 weeks, we understand what the volume could be over the next 2 to 4 weeks or longer. And therefore, we can make the scheduling and smooth some of that out, make sure that we have the right numbers of staff for the volume that is coming in based on volume and acuity, and to be able to do a lot of that work. What it's done for us over the last 10 years is help us drive our actual finances associated with that. It's become a science, and so year over year, nursing is oftentimes looked at with our C-suite executives as a division across nursing services as being right on target year over year and not much of a challenge related to our staffing patterns.
Well, let me invite Brandy you into the conversation to talk a little bit more about some of the outcomes and how this program has impacted patient care and nurse at the bedside, if you will.
So when we implement, our acuity-based staffing, we look at that in our staffing huddles twice a day, and so before shifts. So we're able to, as a leadership team, come together and determine and allocate resources for the upcoming shift based on the need of the patient. So we're able then to take resources throughout the hospital and help with the demand of the patient. So for example, if we have high acuity patients on the unit, we're able to allocate more staffing resources for that. We've actually seen a lot of, as far as our patient nurse satisfaction scores, improve with some of the ways that we're doing staffing by acuity. So they feel like the way that we're staffing and the way that we're doing that based on, they can have a patient load. We don't go by staffing ratios as mentioned. So we're able to give a patient load based on acuity and go back and look at how many patients, what kind of patient load you have and how does that impact the hours that you're able to provide for care of this patient. So the RN satisfaction scores have improved around some of that work. A lot of our outcomes are above national averages, our pressure ulcers, all of the nursing outcomes, our falls, and a lot of those kind of things. So we're able to stay above the mean for a lot of our outcomes in those areas based on some of the work that we're doing with the acuity and the patient assignments.
And if I can add to that, just to quantify some of those patient outcomes that Brandy's talking about, we have a medical department and several other departments that have gone more than 2 years from the current date without a catheter-associated urinary tract infection or a central line-associated bloodstream infection. And we've seen extended periods of time, even with the falls without an injury. It can't all be associated with the patient classification system and the assignments. There's a lot related to the culture there too. But clearly, over the last 10 years, using a valid and reliable tool that maps our documentation and the workload of the nurse into the patient classification system, we have seen tremendous results on patient experience and quality outcomes, as well as the nurse satisfaction. I think 5 years in a row, we've seen improvements in all of our nursing departments on their RN Indian QI satisfaction survey, and across the organization, we're above the mean in all of the categories associated with that RN satisfaction.
Let me draw you out a little bit more about the patient experience. How is their experience different? Are there stories along those lines that you can tell?
Just an idea on the patient experience. About 90+% of all patients that have an experience within the hospital would show that our care and services are good to very good. We think about it from that perspective of, on a scale of 1 to 10, from 7 to 10, 90% of the patients would say that 90+% of them would show that our care and services are very good from that perspective. In the emergency department, the patient classification system that we use is primarily for the inpatient side, but we took a lot of the methodology associated with that predictive analytics and applied that in the emergency services area. And for a significant period of time, when you look at even the top box in emergency services, that department there were functioning at the 90th percentile or the top 10th of the hospitals our size. And we see about 70,000 patients a year through the emergency department. So it's a high volume ER, and we're delivering on that excellent services using the same predictive analytics modeling in the ER as we did on the inpatient side, where at least 90% or more actually show improved patient experience in our nursing services.
Because you've got the acuity and the volume and the staff skills matched up, then I can imagine that maybe the care for the patient is maybe a little bit more streamlined, maybe less downtime between, waiting for a physical therapist to come in because you already could anticipate the patient's needs and so forth. Brandy, when you have the kind of daily or twice-a-day huddles with staff, are those the types of issues that you try to get ahead of?
Yeah, absolutely. And we actually implemented a huddle with our hospitalist group. So every day in the evening, we go through some of that information. So we talk to them about, not only care of the patients and what's going on with some of the patients with the nurses, but also some of the staffing and some of those analytics and what we've got going on. And it helps, I think, plan their day. They're aware, as from the hospitalist and physician group, what's going on, from the nursing standpoint, from the census, the acuity of the patients, and that kind of thing. So they kind of understand their workflow and what's going on. So that's something new that we've done over the last few months. That's been very beneficial. It's impacted, again, the patient care. It's impacted our care of patients, especially overnight. But we've used some of that information in those huddles also.
And as you sort of think about lessons learned, and Brandy, maybe I'll start again with you, what comes to mind as far as lessons that you have learned about what makes this work and maybe some kind of surprise learnings along the way?
I think the communication with the leadership team is big. I think they have to understand the information, how to use whatever tool you use, however you're putting in your data, putting in your information. They have to understand it. They have to be, communicate why we're using it, what it's for, be able to communicate that to the frontline staff. What is this information? How is it useful to you? How can you use it personally? How are we going to use it to impact patient care? And really understanding that from not only the leadership perspective, but also a direct care nurse perspective. And so including, your direct care nurses in some of those conversations, I think is really important, and understanding where the information, how it's put in, how it's used, where that information comes from, how it's used to get the data and, then the outcomes, whether that's a target to schedule analysis and how that shows you how we adjust staffing levels based on patient acuity, and whatever that looks like, being able to communicate that to the frontline staff and helping them understand exactly what all that information means and how it's helpful to their patients and to their patient care.
Brandy, perhaps you can talk a little bit about the Nurse Staffing Advisory Council and the use of the predictive analytics within the patient classification system, and your doctoral work around alternative shifts to combat fatigue-causing shifts.
We have a very robust Nurse Staffing Advisory Council, and so 60% of that council is made up of direct care nurses. We've been able to do a lot of work there from the information we get from our system. So, for example, we looked at volumes for some of our inpatient areas around our surgical volumes, ADT volumes with, our admissions, high admission times, discharges and transfers. So we implemented what we call a task nurse. And so we've been able to provide 4-hour, 6-hour shifts, additional time for staff to come in to help with and manage some of those increased turnover times. And so we were able to use the system to do some of that work. We've done some things with staffing on being able to take our full-time staff to an every third weekend rotation, and that's using data and information from the system. We're also able to bring information to the Nurse Staffing Council on variances, overtime work, so how we're budgeted, which is big, and then how we're actually running or comparing to that budget, what our actual work is doing to that. So getting them information on what our budget looks like and then how we're actually running. We've also got data on how that staffing impacts our outcomes. So we're able to bring in information about what does the staffing levels look like, and then how is that compared to what our outcomes are, as far as some of those, the CAUTI's collapsing. So my doctorate work, we did some research on alternative staffing levels. So understanding that 12-hour shifts are fatigue-causing shifts, and that nurses at the end of the day are burnout, dissatisfaction at work, and things like that. So through the Nurse Staffing Advisory Council, we developed a work group, a task force, to look at that research. We had 2 frontline staff members who helped develop or look at what kind of innovative things we could do as far as starting to move away from a 12-hour shift. And they developed a 9-hour shift model. So we implemented and did a test of change in one of our units with the 9-hour shift model, including an hour in that time, that hour for overlap. So they had an hour to do shift change, and then being able to cut down on our overtime. So one of the things that we saw with the implementation of a 9-hour shift is our overtime was a little bit more in control. So nurses didn't feel like they were here all the time. They didn't feel like they were at work long during the day and here a lot of time during the week. So we were able to cut down on some of that. And the nurses would tell us that it felt like they could, they had family in town. One of the nurses had family in town, and she voiced how she was able to leave and actually visit with her family at the end of the day. She felt like she was able to go and have dinner with them, looking at that alternative shift model and being able to look at some things with staffing and how that impacted change in that. And that came out of our Nurse Staffing Advisory Council.
Yeah, I can imagine that it really does contribute to increased satisfaction among the nurses when they kind of feel as though there's kind of a whole system in place looking at what work needs to be done and who can do it and so forth. Bob, when you think about future plans and how this process may change in the future or things that are on your wish list, is there anything that comes to mind?
I think from our perspective in looking at nurse staffing, I think we need to broaden that lens and look at interprofessional staffing based on the patient needs. And so whenever we recognize and we're able to track on the electronic medical record into the patient classification system, I'll give you an example. On a patient that comes in perhaps with a pneumonia diagnosis, does it really take all the time for a registered nurse, or could you map within the patient classification system and the scheduling to use our interprofessional colleagues like respiratory therapists in the care of that patient and reduce perhaps the overall cost without suffering on the quality or the patient experience? We think so, and so that's one of the questions that we'll continue to explore, whether it's in the Nurse Staffing Advisory Council or even a task force of that includes the interprofessional colleagues to do a test of change with pneumonia patients in the skill mix change. With the IOM and the triple aim, not necessarily the quadruple aim of caring for the caregiver, but improving cost and quality whenever the patient is in our hospital is a target that every healthcare executive has. And I think using predictive analytics more so, and whether it's in the staffing realm of this or even looking at the clinical indicators, there's predictive analytics on that as well, where you drive outcomes versus reacting to the patient needs as they come up. And we're continuing to explore other technologies that are already in existence that get to some of those kinds of predictive analytics. Our patients, one, deserve high quality care and experiences within the organization. But I think our professional staff, interprofessional colleagues, Brandy talked about the hospitalists. I've already mentioned the respiratory therapists, but we think about physical therapists and others. People want to show up and they want to do what's right by our patients in the organization. And so by providing the kinds of tools that these platforms provide for us, it opens up those doors to really think creatively or innovatively in order to staff appropriately, reducing the overall expenditures that a hospital sees, recognizing the continuation of declining reimbursements that we see across the country, and all the pressures that are given to healthcare executives. By having something like this in place, it will assist chief nursing officers and chief operating officers and others to continually talk about the evidence that supports evidence-based staffing assignments that drive that quality and patient experience. And so I see that this is going to continue to evolve over time.
Well, it sounds as though you're really on the path of some innovative work where everybody benefits. So congratulations all around. Any closing thoughts that either of you would like to weigh in with?
From my perspective, I think, on the patient classification system, the predictive analytics, one, for nurse leaders, as we focus on nurse leaders, having the business acumen to be able to discuss the value of those platforms. I think Brandy talked a lot about on the Nurse Staffing Advisory Council, the ongoing conversations and huddles throughout the day and with our interprofessional colleagues. But it takes resilient leadership to be able to make this work. You can't just implement something and sit back. You have to make it part of the ongoing sustainability of the organization and walk that talk all the time. Brandy does a fantastic job of leading those conversations and having those conversations within our Nurse Staffing Advisory Council and those meetings. But if you don't do that on a day-to-day basis or even multiple times a day, you may backslide. What this predictive analytics system does for us is makes all of that visible and transparent and improves that communication, which improves teamwork and that relationships between departments. And as we build that trust and relationship, the more the opportunities exist to be more creative and innovative in how we staff and move away from the traditional staffing patterns and really get to what matters to the patient and what matters to our teams. And that's what this system does for us.
Well, it certainly does sound as though using predictive analytics to manage the nursing workforce is having a significant and positive impact at Midland Memorial Hospital. So I want to thank you, Bob and Brandy, for joining us today and sharing more information about this important initiative. It truly is an excellent example of implementing operational solutions to decrease cost, improve quality, and improve the patient experience. For more podcasts and additional tools, resources, and education to help you advance affordable health care and promote value in your community, please visit the Value Initiative's website at aha.org/the Value Initiative. This concludes our discussion today. Thank you for listening.